The purpose of this session is to talk through a case study example for metastatic spinal cord compression. Metastatic spinal cord compression occurs where there is pathological vertebral collapse or direct tumour growth causing compression of the spinal cord, which may result in irreversible neurological damage and possible paralysis. It is therefore classed as an oncological emergency. Around 85 to 90% of metastatic spinal cord compression occurs from extradural tumours. The other 10 to 15% are intradural, either intramedullary or intradural extramedullary tumours. Case study 3 is a 76-year-old male with a new diagnosis of gastroesophageal cancer, clinically staged as T2N2M0. He was not known to oncology and was under the care of the gastro team at the local trust, and we were informed that he was for best supportive care, although at the point of presentation to us, point of referral, it wasn't clear what the decision was and why the decision was made around best supportive care versus any active management. He was referred to Walton for a spinal opinion 3 months previous to this referral to the MSCC pathway, with query spinal malignancy versus discitis on a whole spine MRI, and he was given antibiotics at that time, and they suggested that they reassess following the antibiotics with re-imaging around 6 weeks later. So he was referred to the MSCC pathway by a hospice 3 months later when the patient had presented with generalised back pain radiating to his chest and reduced power and sensation in his bilateral lower limbs. So the MSCC pathway for this patient started with the hospice contacting the MSCC coordinator for advice. The MSCC coordinator advised that the patient be sent to A&E for urgent assessment, given the neurological deterioration, the history of cancer, and the known spinal issue previously on MRI. So the MRI was requested as urgent within 24 hours, and it was completed and reported the following day within that 24-hour period, so met the requirements, met the guidelines. The repeat MRI was reported to show progressive worsening of signal abnormality around T6 and T7, with interval further vertebral body destruction and posterior cortical expansion leading to significant indentation of the cord without cord edema. Extradural fluid appearing collection from T3 to T78, causing posterior thecal sac indentation. And the radiologist noted the clinical history that mentioned that changes have been previously thought to be due to metastatic esophageal carcinoma rather than discitis. However, the appearances on this scan could represent worsening discitis. So further investigations were required. The first was neurological assessment to assess the clinical impact of the compression and to guide the urgency of management, and pain assessment to support the management of patient symptoms and assess spinal instability. The patient had had a recent PET-CT, so within the last 8 weeks, so there was no requirement for urgent or further CT staging at this point. So these images show the difference between the imaging from November to January, so within that 3-month period. So the images from November on the left-hand side were reported to show discitis, and the patient was started on antibiotics. The images on the right-hand side under January are the new MRI following progression of symptoms, and you can see on that sagittal view from T3 down to T7 compression of the spinal cord and cord edema. So the initial management in this particular case, and cases like this, are quite challenging because we're dealing with a potential malignancy which may be causing a malignant spinal cord compression, but we may be dealing with a non-malignant cord compression, in which case oncology management isn't appropriate for this patient. So the initial considerations are based around the patient's symptoms. So the patient is symptomatic from cord compression. So steroids were indicated and the patient was put on bed rest in a position of comfort. So a position of comfort means exactly that. They're not necessarily having to lie completely flat. The position needs to optimize both their symptoms from the cord compression, but also their general well-being. So enabling them to eat and drink, reduce risk of aspiration, and any other chest complications, and try and prevent deconditioning where possible. But that position was maintained whilst awaiting assessment of spinal instability. So the second thing is that this is an unknown spinal histology, possibly non-malignant. and the spinal surgeon opinion should be followed as per the guidelines. So you can see here the flowchart for assessment and management of a patient with a malignant cord compression, and in this case a potentially non-malignant pathology. So as the patient had a known cancer, oncology opinion is still important to the surgical team in many of these cases in terms of determining appropriate management. So whether this patient would be a surgical candidate without the malignancy, with a malignancy, the surgeons would want to understand the impact of that malignancy on their surgical options and on their prognosis and on their potential outcome. So for example, if they would do surgery radiographically for this cord compression, is that surgery going to impact their oncology management? What's their prognosis? Do they have oncology options that mean that if these are delayed, that would be detrimental to their overall prognosis and quality of life? And where does that balance sit? And that requires a conversation between the oncologist and the spinal surgical team. So following the flowchart for a potentially non-malignant pathology, we don't have histology at this point, and we don't know whether it's appropriate to establish histology. So for the non-malignant pathology, this fits into the category of benign or degenerative with neurology or infection, and it sits in both of those camps. The patient has neurological deficit and a potential for infection. So the local team should complete an emergency neurosurgical referral to the Walton Centre. So that referral will be done by the local team because this is potentially not an oncology issue, but Walton may require the input of oncology to guide in terms of suitability of surgery. So the management plan for this patient case. So the first thing was to get a second radiology opinion with a specialist radiologist, and the radiology opinion suggested this was more likely discitis. So as it was likely non-malignant, there was no role for radiotherapy in the management of this cord compression. The patient had also declined surgery for their esophageal cancer and were not therefore for spinal surgery. They were considered for a spinal orthosis or brace, for pain management, and the management plan was to optimise analgesia and provide best supportive care with consideration of palliative radiotherapy for their primary esophageal malignancy.